Hello, my name is Bob Gailey. I'm a physical therapist, and I'm here to talk to you today about the next generation of the RHEO knee, and in particular the gait training that goes along with somebody who will be using this knee. And what we'd like to do is start off looking at the assessment of the amputee prior to the gait training. There are 6 critical features that we look at in gait assessment. The first is walking width or base of support. Normal base of support is about 2 to 4 inches. So what we'd like to do is see a nice symmetrical width of walking base when the amputee is standing. When we see the dynamics of the walking width, as we'll see with Gil, notice that the sound limb tends to come to midline. This means that he's putting most of the weight on the sound limb and not sharing the weight with his prosthetic limb. Gil, come on back. What we want to do is have a more symmetrical width of walking base, and this is something we'll talk about in just a few minutes. The second issue we want to look at is stride length. So as we watch Gil walk, we want to make sure that each limb has a symmetrical stride. Typically what you'll see is the person taking a shorter, faster step with the sound limb, which means they're not balancing over the prosthetic limb. The third issue is dynamic weight bearing over the toe of the prosthesis. As Gil walks, what we want to see is, does he load the toe of the prosthetic foot in order to take advantage of the full dynamics of not only the prosthetic foot, but also of the RHEO knee. The fourth issue is transverse pelvic rotation. Prosthetic knees are designed with the intention that the amputee is going to have normal pelvic motion so that you can have normal weight bearing throughout the prosthetic knee. So as we watch Gil walk, go ahead Gil. As he does, I put pressure on the sound limb as I can't stop him. As I put pressure onto the prosthetic limb, he tends to fall back over the sound limb. What we need to do is educate him how to restore normal pelvic rotation. The fifth issue is looking at knee flexion. Typically what happens if you don't have normal pelvic rotation, you're not going to get normal knee flexion. And that's really the essence of using the RHEO knee. So when we ask Gil to walk, notice that as he lifts and he kicks the prosthetic limb forward, is that he doesn't have the normal knee flexion that we would hope he would have with this prosthetic knee. This we can restore with proper gait training. And finally, the last issue that we want to evaluate is trunk rotation. Once we restore pelvic rotation and the person is comfortable walking over their prostheses, we would expect to see normal trunk rotation. However, many folks with limb loss tend to lose trunk rotation when they walk with their prostheses. So as we watch Gil walk, notice that we don't see arm swing, and as a result, we don't see the trunk rotation that we would expect to see, which would actually cause the arms to swing. To initiate prosthetic gait training, one of the first things we like to establish is control of the center of mass over the base of support. This can be done simply by educating the person with the prostheses as to where their center of mass is. Typically what I like to do is to take my fingers and to move them back and forth simultaneously somewhere around mid-sacrum so that they have a sense that I'm pulling a string through the center of their pelvis. What I'll ask him to do is to imagine in the center of the string is that there might be a blue marble, and that he wants to move this blue marble over his base of support, which would be the outside of the prosthetic limb, and then moving that same marble over the outside of the sound limb. As he displaces that center of mass from one side to the other, he gets a sense of how far he can move that center of mass and still maintain his balance or stability. As Gil gets better with this, what I would ask him to do is to remove the sound side hand so that if he still wants support, he would go through the prosthetic side limb in order to get support from the parallel bars. Once he's confident with the displacement from side to side or laterally, what I would do is then ask him to remove both sides and do the same shift, first over the sound limb, then over the prosthetic limb, until he becomes comfortable and confident shifting his weight over both limbs. To progress, what I would do is then ask him to put both hands back onto the parallel bars, reestablish where that imaginary ball is in the center of his pelvis, or his center of mass. Then I would ask him to now move his center of mass forward equally over both limbs, and then come all the way back over his base of support. As he brings the center of mass forward, the heels will rise. As he brings it backwards, the toes should rise. In order to keep or maintain that center of mass equally between both limbs, sometimes I will place my hand along the side of the prosthetic limb, since they tend to shy away from the prosthetic side, and put a little bit of pressure. This gives him a sense of wanting to push into my hand and develop a more equal displacement of the center of mass. Again, I then will remove the sound side hand, having him move forwards and backwards. And when he becomes more confident, I'll take away the prosthetic side hand, and again having the toes come up, and then having the heels come up. And now he's learning how to displace that center of mass both forward and backwards over the prostheses. Finally, I want to work diagonally. So the hands will go back onto the parallel bars. I will first ask him to move the sound limb forward. This way the weight line will be anterior to the knee, creating a sense of stability. Then I'm going to ask him to diagonally move that blue marble over the the sound side toe, then back over the prosthetic heel. Come over the sound side toe, back over the prosthetic side heel. As he shifts that center of mass from side to side, it gives him that same sense of displacement that he'll have during walking. Then again, he'll move the sound side hand, and then finally, he'll remove the prosthetic side hand. I'll then ask him to put both hands back on the parallel bars, and then we'll reverse the process by bringing first the sound limb back, then bring the prosthetic limb forward. And in this occasion, especially with the RHEO knee, the idea is to give that person the sense of having the stance control within the knee. Because the knee is going to flex somewhere between 8 to 15 degrees, I want him to have that sense that as he moves that weight forward, the knee will first flex, and then it'll extend as his weight moves over the prosthetic foot. So it's the same idea. He shifts that weight forward, allows the knee to bend, and then moves over the prosthetic toe. And so we shift the weight over the prosthetic foot, allow the knee to flex, come over the toe. As he builds that confidence, we can remove the sound side hand, bringing that weight over, and then we can remove the prosthetic side hand, and now he's gaining a full sense of the capabilities of his new RHEO knee. And I'll ask him to put both hands back, bring the leg back, and now we've built up that ability for him to displace the center of mass in multiple directions and do it with confidence. How to restore normal pelvic rotation? We start by looking at his step or his stride with the sound limb. As he steps forwards and backwards, I can slide my hands in and assess pelvic rotation by feeling the anterior superior iliac spine. I then ask him to remove his left hand, and as I push, I realize I cannot alter his balance because he has the ability to bounce over the prostheses and maintain the power of the pelvis on the left side. To restore normal pelvic rotation, we first work with the sound side, in which Gil has the ability to rotate his pelvis, and with slight resistance at the ASIS is that we give him the sense from mid-stance to pre-swing of bringing the pelvis forward in that transverse plane and rolling over the foot and allowing the knee to bend. The next step is to have the person actually take a step with the sound limb, feeling the continuation of pelvic rotation, taking a full step, allowing the weight to come fully over the prosthetic limb. Once they get a sense of how to do this maneuver on the sound limb, then we can progress to the prosthetic limb. To continue the assessment, we now evaluate the prosthetic limb. And notice is that there's very little knee flexion as he tends to hip hike and kick the prostheses forward. Again, I bring my hands in and place them on the anterior superior iliac spines. I then ask him to take his prosthetic side hand off the parallel bars, and when I apply a slight pressure, we see him fall back over the sound limb. This is the chief problem with most prosthetic wearers. As they lift and they kick, they lose balance on the prosthetic limb because they haven't learned to bring the pelvis forward. And this is the purpose of this exercise, is to give him maximum benefit from the RHEO and maintain balance and be able to walk with a natural gait. The same process is now performed on the prosthetic side limb. In order to get the pelvis to rotate, I give slight resistance to the ASIS of the prosthetic side limb, shifting the weight over the sound side foot, and notice the increased knee flexion that takes place. So the idea is that the amputee brings the pelvis forward, allowing the knee to achieve its 30 to 40 degrees of knee flexion during pre-swing, so that it will easily achieve the 60 degrees of knee flexion that it's going to need during initial swing. To continue resistive gait training, we resist the pelvis on the prosthetic side, teach the person to achieve the full knee flexion with their prosthetic limb without throwing it forward, and by rolling the weight over their sound foot. As they do this, they learn that they can easily flex their RHEO knee, and they can achieve the stability they need when it strikes the ground. The continuation of resistive gait training is performed outside of the parallel bars, where I'm going to ask Gil to put his hands up onto my shoulders, and I'm going to apply the same resistance I did inside the parallel bars to give him that sense of how to roll over each of his feet and have the prosthetic limb behave the way that it should. As he walks, I just a slight resistance through the advancing limb will give him that sense of how to take nice equal strides with either foot. Finally, I'll ask him to, again, as he walks, continue and then lower the left hand, then the right hand, and then he's going to be ambulating independently with the use of his new RHEO knee. The final component of gait training is trunk rotation. Once we've established normal pelvic rotation, combined with trunk rotation, the amputee will be able to walk at a comfortable walking speed with better balance. So we're going to ask Gil to walk and just think about using his pelvis as we've just taught him. Then I'm passively going to move his trunk with my hands to give him that sense of rhythm between the pelvis and the trunk. I might remind him, in this case, to move his left shoulder forward. As he does so, he starts to become more comfortable and tends to have a less deliberate and a more symmetrical walking posture. He then rotates the trunk, and we see a beautiful gait. In order for Gil to take full advantage of his ceteris flex foot and his RHEO knee, what we want to apply is a full toe load. We can do this simply by applying a little resistance with a gait belt as he ambulates. So we're going to ask Gil to go ahead and walk, and as he does, I simply hold back his body weight so he gets full weight over the toe lever of his flex foot. As he walks back, he gets a sense that he can take a longer stride and therefore fully weight bear and maintain better balance over his prosthetic foot. Then I let go and he feels the dynamics of the foot. We ask him to turn around, come back, and now we typically will see a longer, more symmetrical stride on both feet. One of the key advantages to the RHEO is the low resistance the amputee experiences when trying to make a turn or to ambulate in close quarters. To teach somebody how to turn with the RHEO is quite simple. We have our person walk. Gil, if you would walk for us. And then as he makes the turn, we want him to rotate the pelvis and toe load as he comes over the foot, and then start to just feel comfortable that he can trust and balance over the prostheses. As he continues to rotate and walks down, he then realizes he can now make a nice, easy turn, share the weight between both limbs, and have a very natural and smooth looking gait. The more difficult of the turns is when the amputee is going to turn towards the sound side. So we're going to ask Gil to go ahead and walk, and as he does, we want to remind him again is to take short, meaningful steps, and as he does so is to again load the toe as he progresses over the foot. Again, the beauty of the RHEO knee is that there's very little resistance, therefore the turn can occur smoothly and with very little effort. One exercise that most people find very useful is performing figure of 8s between two cones. So we're going to ask Gil to go ahead and to walk and to concentrate again on feeling the prosthetic foot, relying on the knee, maintaining single limb balance, and as he does so, he gains greater confidence in his RHEO knee. Many amputees would like to be able to sit in a controlled fashion. This is one of the benefits to the RHEO knee. By learning how to use that resistance, they can sit in a chair in a very controlled and natural manner. It's simply done by having the therapist push against the knee, therefore bringing more weight over the prosthesis. As they do so, the amputee then begins to descend into the chair, reaches back for the arm of the chair, and as they do so, they learn to ride the RHEO knee down so that they can sit in that controlled fashion. If we practice one more time, Gil will do it on his own. He then loads the knee, rides down, uses his arms, and voila, he's sitting in a nice, comfortable fashion. When teaching stair descent with the RHEO knee, there are three critical factors that we want to keep in mind. One, foot placement. We want to have the foot about halfway off the step, therefore we prevent toe load, which might cause some buckling with the knee. Secondly, we want the person to maintain their body over the knee so that they get full body weight and therefore they can take advantage of the resistance that the RHEO knee will offer. Third is that we want them to use their hamstrings against the posterior wall of the socket. Therefore, they can control the amount of resistance release as they descend the stairs. In order to practice, what we do is a little static training where we'll have them step up and down on a single stair. So we'll have Gil go ahead and descend one stair, allowing the foot to come down, and then bring the RHEO knee down, and now come back up, and we'll practice again. This builds confidence and also the knowledge of how to properly use the knee when descending stairs. Finally, when he's ready to descend the stairs with a little bit of confidence, we allow Gil to descend the stairs using his RHEO knee and learning how to achieve the resistance the knee has to offer. Go ahead, Gil. And he descends the knee, descends, and descends. Another benefit to the RHEO is the resistance that the knee will offer when descending inclines or small hills. The way that the amputee can control that is again by pushing against the posterior wall of the socket and then just riding the knee down, releasing the resistance or releasing the knee as they feel necessary. So one of the ways that we practice is coming towards the end of the ramp, and we'll ask Gil once again, is to push back against the back of the socket with his hamstring and ride the knee down. And he takes a step back up. Again, as he becomes more and more comfortable, he realizes is that he can step down with a more slower descent, a more controlled descent, and with better balance. Gil? And one more time. And as he practices this skill over and over again, he then is ready to go ahead and descend the ramp itself. Now that Gil is ready to descend this ramp, he's just going to put into practice the skills that he learned in the drills before. He's going to use his hamstrings to control the resistance of the RHEO knee as he descends the ramp. Gil? And there you have it. In a nice, controlled manner, he descends the ramp. And a good rehabilitation program should include some home exercises. So what we're going to ask Gil to do is one that will work his hip in multiple directions and building the strength of the hip muscles inside its environment, the socket. We're going to ask Gil to put his left foot on top of a regular tennis ball and have him move forwards and backwards as quickly as he can for 10 to 20 repetitions. As he does so, he's strengthening the muscles about the hip on the prosthetic side in the sagittal or AP plane. Then we're going to have him move from side to side. As he does so, he's still working the muscles creating stability in the prosthetic side, but now he's working in the coronal or frontal plane. Finally, we're going to ask him to move in a counterclockwise position. As he does so, again, he achieves stability with the prosthetic side hip, this time in the transverse plane. Finally, we ask him to reverse direction. He goes in a clockwise direction, again, using the muscles about the prosthetic hip to maintain stability. Doing these exercises for about 50 repetitions, 1 to 2 times a week, will maintain the strength of the residual limb inside the socket. Another exercise that can be performed to strengthen the muscles about the prosthetic hip is to take a small strip of therotubing tied around the parallel bars or a sofa at home. Have the amputee hold onto a chair or the parallel bars. We're going to ask him then to move his sound limb away from the prosthetic limb. As he does so, he's using the muscles inside the prosthetic limb to maintain stability. Once he performs 10 to 15 repetitions, we'll have him turn, again face the parallel bars. Once turned, he then extends the limb, again using the prosthetic side hip to maintain stability. Then we turn. The next position, we have him cross the sound limb over the prosthetic limb to work on the adductors. And finally, we have him turn, kick into a flex position, again holding on to the limb, working in the anterior-posterior direction. At the conclusion of prosthetic gait training, the amputee should be able to maximize the use of their prosthetic components. As we watch Gil walk, is the issues that we earlier described are no longer present. He has the ability to maintain normal width of walking base. He's taking equal and symmetrical strides with both limbs. He's able to maintain full toe load over the prosthetic foot. He achieves normal knee flexion with his RHEO knee. He has normal pelvic rotation combined with trunk rotation. He has better balance. And at the end, we see is matching the proper prosthetic components with proper gait training is the amputee is able to achieve their prosthetic goals.